So good afternoon and good evening to everybody. Thank you for being with us. It's a proud privilege, and on this occasion, I'd like to welcome you for the first virtual Asia Pacific Hepatitis Summit, which is organized by three partners: International Institute for Human Development, Global Coalition for Hepatitis Elimination, and ILETS. So in the morning, we had an interesting session where the eminent speakers, they spoke about the challenges in terms of diagnosis and the linkage to care. So in the second session, we are going to talk about how the public and the private partnership is going to help us to identify the missing millions, which is the theme for this year's on the World Hepatitis Day. So with these words, and since you're already delayed, I would like to hand over the session to our convener for this summit, Dr. John, who is the director for Global Coalition for Hepatitis Elimination, and he is going to organize this session for all of us. Over to you, John.
Thank you very much, Prasan. Good day, everyone. It's great to be part of this Asia Summit to explore the challenges regarding hepatitis B and hepatitis C testing so that we can achieve our hepatitis elimination goals. Our challenges are that we have about 257 million people living with hepatitis B and about 71 million people living with hepatitis C. And over 500,000 people are dying every year of hepatitis B or hepatitis C. And about 40% of those hepatitis B deaths are in Asia, and about 35% of those hepatitis C deaths are in Asia. We know we have effective treatments that can prevent those mortality, including the cure for hepatitis C. The challenges are the small proportion of people, 10% for B, 19% for C, who have been diagnosed, aware of their status, and only a fraction of those are receiving treatment. So the challenges for us is how to get those people tested. In session one, we began to explore the different elements of the right technology, the need for right policies and political commitment, how you deliver those effectively at the point of a patient care or in a community setting, and then the importance of data to understand where you are so that you can improve your program over time. So we're going to be looking and continuing that conversation in this session and to really fully explore different options. We heard from a variety of different programs in session one, and we're going to continue to look at different programs here in session two. So I'm going to turn it over to Dr. Kumud Rai, who's the chairman of the ECHO Trust here in India, to learn about Project ECHO and how it is a model of telehealth learning that brings together specialists in primary care to expand access, in our case, to hepatitis testing and treatment. Dr. Rai?
Good afternoon, everyone. Is my screen visible? Yes, I think I can see that. So I'm going to talk today in this session about, the session is titled, What Strategies and Public-Private Partnerships Help Governments and Address Access and Affordability Issues of Hepatitis Testing. I thank John and all the organizers for calling me over for this presentation. So I'm going to talk about the Project ECHO initiative for capacity building. It's my privilege to be the chairman of ECHO India Trust, and I also serve as director of vascular surgery at Max Healthcare in New Delhi. So the full expanded form of ECHO is Extension for Community Health Outcomes, This was founded at the University of New Mexico in 2003 by Dr. Sanjeev Arora. And
Dr. Kumud, can you please share your screen? We are unable to see your screen.
Oh my God. I'm so sorry. I thought it was showing on my screen. 1 second.
Okay.
Is it showing now?
Yeah.
Not,
1 second.
Not yet.
I don't know. I have it in front of me, share screen, but let me do that once again. Sorry about this. Let me try and do this once again.
Sure.
I don't know why it is happening, because when I'm pressing on the share button, it's not coming on. The default setting is cancel. Can the organizer help me, please?
Yeah. Deepak, can you share Dr. Kumud's slide, please? Yes.
That looks promising.
All right. So I think I'm already on, and I'll request you to please change them. I've already talked about it. Next slide, please. The next slide, please. So as I was saying, Project ECHO stands for Extension for Community Health Outcomes. It was founded in 2003 at University of New Mexico, USA, by Dr. Sanjeev Arora, and in 2008 in India. It's a model for capacity building, but much more. It's a societal platform, a digital platform, and I'll very briefly spoke about it. The heart of this is the hub and spoke model, where at the hub, an expert or group of experts get together and talk on a regular basis with the spoke, that is the participants, and in this instance, healthcare workers. ECHO has hubs in 43 countries. In the heart of it, while it's a hub and spoke model, is all teach and all learn. We learn as much from the participants. The experts learn as much from the participants as the participants learn from them. Another key message is moving knowledge, not patients or providers. It is to democratize or demonopolize specialist knowledge and pass it on to healthcare providers, physicians, nurses, etc. And so that the healthcare delivery becomes better. And the stated aim of Project ECHO is to touch 1 billion lives by 2025. Next slide, please. So this is how it looks like. In the center is the hub where Dr. Sanjeev Arora and his team is sitting. And in this instance, there are 7 people who have joined for this clinic, or the program as we call it. And very rapidly, it's a very interactive model. And I'll come to that, where case-based learning is a very important part. They will quickly present their problem cases to this expert in a template, and solutions will be provided to them, and they will be discussed by everyone. And the beauty is that when this is done week over week, month over month, year over year, the knowledge transformation is remarkable. Next slide, please. And these are the four pillars. A stands for amplification. We use technology to leverage scarce resources, in this case, specialist time and the movement for a physical meeting. Best practices are shared so that disparity is reduced. We encourage the hub participants to share their the global best practice or the country's best practice rather than their own sort of thought. Case-based learning I've already touched about. It's less about didactics, more about management of real patients, because then it's like teaching someone to catch a fish, and so that he can be good at it and he can keep providing for the rest of his life, either to himself or his family. And the last D stands for we use a web-based database to monitor some of the outcomes in these cases. Next slide, please. So it is being used to train physicians, nurses, mid-level health workers, that is MLHW stands for, the ASHA workers, educators, And we also use our own software called iEcho. We conduct these tele-echo sessions. As John said, it is a bit of tele-learning. We prefer to call it tele-mentoring, and initiate best guided practices through case-based learning. Next slide, please. So this is our spread in the country. You can see here we have 35 active hubs across 11 states. Some states have poor connectivity, so we haven't reached there yet. And these are the diseases you can see, from autism, cancer, COVID, to HIV, tuberculosis, mental health, ophthalmology, pediatrics, quality management, and tuberculosis. So all of these are these area 22 disease areas. Project ECHO in USA takes care of actually 70 such disease areas. Next slide, please. And these are our partners for our COVID response. You can say 47 partners, and we are very proud to say that we are a signed partner of the government of India, and we are into several national programs. Next slide, please. So, and we have trained in this COVID response, which in the last 4.5 months, we have conducted over 1,000 sessions, provided 1,650 hours of training. So each session is around 1.5 hours, some have been longer, and helped train a workforce of 298,000 plus people. These were the folks who joined. So the actual number who benefited may have been more, because it was a very rapidly developing program. We don't have the exact numbers, but it is at least 300,000. Next slide, please. And this will give you a glimpse. This is the largest one webinar we held, where there were over 5,000 participants in 555 out of some 638 districts of the country, right from Jammu to down south. And you can see through this map that over 5,000 participants were familiarized with the basics of COVID management in this session alone. Next slide, please. So hepatitis C has been very close. The first program which Dr. Arora ran was for treatment of hepatitis C, where he mentored about 20 odd spokes and asked them to treat these patients. And he thought, can they treat them as well as I can in a university hospital setting, in a medical college? And what would be the results? Next slide, please. And the results were amazing. And this has been published in the New England Journal of Medicine in 2011. The cure rates were identical, whether it was treated at the University of New Mexico Hospital or by the ECHO centers, roughly around 50, 46, and 70, 71%. More importantly, they also showed that the minorities got a much better response rate when they were treated out of ECHO, because by the ECHO physicians, because they were treated close to their homes and they could complete their treatment. Those were early days when ribavirin was used, so the cure rates were only in 50s and 70s, unlike the 90s we have today. Next slide, please. In India, Professor R.K. Dhiman of PGI, and I'm sure Dr. Gaganjeet spoke about this, so I'll touch it very briefly. They had a physical meeting with the primary care physicians of 22 district hospitals and 3 universities, held a workshop for them and mentored them regularly in ECHO clinics every fortnight. And they also created a WhatsApp group. At that point of time, when this was published, they had 51,000 patients. I think it is probably definitely in some 90 odd thousand, or maybe it's crossed 100,000. The SVR rates as per the modified intention to treat protocol were 92%, and this has been published in Hepatology this year in 2019, that this model worked very well. This is not to say that ECHO did everything, but it was one small piece in that big jigsaw, which helped complete the picture and which helped achieve the numbers which we wanted to achieve. Next slide, please. So in conclusion, I would say that new care models like ECHO that integrate technology, bring access to HCV care, and for several other diseases, and are a wonderful way to build capacity in any system. Thank you very much.
Thank you very much, Dr. Rai. Very nice overview of Project ECHO as a tool to improve patient care. Now let's turn to Dr. Yang Puvaran, who is with the Center of Excellence in Clinical Virology, the Department of Pediatrics at Chulalongkorn University in Thailand, to talk about one of the newest Hep C elimination projects in Phetchabun Province, Thailand. Yang?
Yes, good afternoon, John. How I can share the slide? Yes. I'm going to share my slide.
Prasad, can you give him some assistance, please?
Deepak, share the slide.
It is okay?
Yeah.
Okay.
Yes.
Very good. Very good. Good. Thank you.
Yes, okay. I am going to talk on this hepatitis C screening experience to optimize the government hepatitis C program in partnership with other diagnostic Thailand experience. Like you know, in Thailand, we have been working on hepatitis for a long time. This is our data to show that the burden of hepatitis C in our country. We did the Zero survey in the year 2014. We found that Thailand is a population around 65 million. And the prevalence of hepatitis C is around 1.2%, or the total number of hepatitis C and anti-hepatitis C positive is around 800,000 cases. If you look to the at the age group, if the younger age, like less than 30 years, the prevalence of the antibody anti-HCV positive is allowed 2.2%, 0.2%, and it higher to 3.2% in the age between 30 to 60 years. And after that, the prevalence of hepatitis C is allowed 1.3% in all age group. If you look to the last slides, you will see we show you the graph on the Phetchabun province and Khon Kaen province, the neighboring province, and the national surveillance prevalence. You see in Phetchabun province, we found a very high prevalence of hepatitis C in this province. Most of them aged above 30 years old. This is the location of the Phetchabun province. The Phetchabun province is the lower north of Thailand. It allows 400 kilometers to the north of Bangkok. The Phetchabun province is one of the provinces which very high incidence of the liver cancer in this area. You see, this is the prevalence of the liver cancer. We did the Zero survey on hepatitis B and hepatitis C. For hepatitis B, we found that at Phetchabun province, among the adult age above 30 years, hepatitis B carrier is around 6%. And for hepatitis C, the preference vary from the north and the south of the Phetchabun province. It's vary from 1.4% to more than 15%. The overall average of the Phetchabun province antibody to hepatitis C positive, it allows 6 to 7%. Last year, we performed the study at Phetchabun province. We random the population age above 30 years old, approximate, the population is more than 30 years old, approximately 500,000. We random population 1 in 100. In Phetchabun province, we have 11 districts, and we number of health center is 14 health center. We random the population to do a research, allow 5,000 to screen the hepatitis B and hepatitis C by STIP test. Our data for the STIP test for the hepatitis C, we compare with the automated ELISA. We use the APHS test. We found that the sensitivity test of the STIP test is around 91%, and the specificity is around 99%. We plan to do the hepatitis C, like the microsatellite elimination in this province. We plan to do by the end of this year at the Phetchabun province. We will register the population age above 35 years. Is approximately allow 500,000 individuals by the STIP test. We will do the STIP test for hepatitis B and hepatitis C, and after that, we will record all of them into the database. The one who positive the STIP test, we will send them to the district hospital to screen. We approximate around 30 to 40,000 subject positive with the STIP test to do the confirmatory test by the HCV RNA. The hepatitis C RNA will do at the provincial hospital, and after that the result will send back to the district hospital for treatment. If you look to this one, the first screening we will do the verbal consent, and after registration for the first consent, we collect the demographic data by the internet. And after we do the hepatitis B and hepatitis C STIP test, if positive, we make appointment for confirmatory test at the district hospital to do the hepatitis C and hepatitis B. For confirmatory test and treatment, we plan to do the second consent by electronic sign consent at the district hospital or secondary care hospital. We approximately estimate around 60,000 hepatitis B or hepatitis C positive. Among those hepatitis C positive, we plan to do the hepatitis RNA testing and physical examination and liver function test. In the case with positive hepatitis C RNA, we will send the data to the district hospital to see the patient will seeing the doctor, and the doctor will prescribe the antiviral drug. The DIA treatment will start at the at the district hospital, and followed by the health promotion center by the nurse. After complete the treatment, the patient will back to seeing the doctor again to see the doctor again at the district hospital. We plan to follow the result of the treatment 12 weeks after the treatment by testing the HCV RNA again. If negative, it means that the subject, the patients, they will kill. And if positive, we will consult the specialist at the provincial hospital. This is my plan at the Phetchabun province. Thank you very much.
Thank you very much, Young. Excellent overview. Done very quickly. Very exciting program that is getting underway in Phetchabun, Thailand. Wanted to turn now to Miss Madeline Addy from Massachusetts General Hospital in Boston to give us some an overview of some tools that can be used to decide what are the right combination of testing platforms for a testing program, and how they can be applied in planning programs to achieve targets for hepatitis elimination. Maddie, are you on?
I'm here. Thank you. Let me share my screen. So I'm going to discuss an online tool that we've been developing in collaboration with FIND that helps to identify cost-effective diagnostic pathways for hepatitis C. This stems from previous work that our team has done with the hepatitis C treatment calculator, with the idea being that once cost-effective treatment is identified, in order to ramp up screening, that we need to identify cost-effective diagnostic pathways specific to certain situations. So in general, a one-size-fits-all approach does not work for hepatitis C testing, which is part of the reason for this interactive online tool. Prevalence can vary substantially by jurisdiction. Differences in populations, such as age and risk factors, can have a significant impact and can also lead to different entry points for care. And differences in budgets and resources between different settings can mean that a testing pathway that works well in one setting might not be feasible in another, or might not be cost effective in another setting. In general, the cost of screening is a large driver of any Hep C elimination plan, so tailoring diagnostic strategies to each situation is important. And so because projects and programs need to make decisions on what approaches to use for hepatitis C testing, we're developing this online tool that's interactive, that will allow users to input certain testing pathways and see which ones are cost effective based on other localized inputs that they've selected. We have currently developed a tool for Georgia, India, Malaysia, and Pakistan, but we're in the process of adding other countries, and it is still under development. The idea is that we will link hepatitis C testing approaches that are selected in the online tool to a model that simulates the natural history of Hep C infection to find the most cost-effective approach. The tool has a user interface where you can select the country, and this changes the underlying disease burden model and the default parameters. So this will change the model in the background and will also change defaults such as costs. Users can then change the cohort size of the general population that's eligible for screening, and certain parameters such as prevalence and target screening rate and treatment cost. Once this part is done, users can then create customized testing pathways. And the way this works is there are these 7 stages, and for each one, there are defaults for the test type, cost, and location, but users can change all of this. So if the test type is different in a different location, it can be changed here. Different costs can be used. If the test location is changed to either the patient needing to travel or a lab shipment being sent out, travel costs and shipment costs can be added, as well as follow-up rates. And so once a pathway is created by the user, they can click this button and add it, and it is added to the tool for analysis. So in this case study for Malaysia, I've added a single site pathway that's more of an ideal scenario where everything is done on site and there's no loss to follow-up. And then I've used the tool to add in another scenario where patients have to travel for confirmation testing, which creates loss to follow-up. So this is kind of an example of how the tool can be used. If users don't want to have to input custom pathways like this, there are also default options for each country. So once a few pathways are selected for analysis, results are generated that look like this, where there are quite a few summaries for each pathway. In this case, pathway 1 is the preferred cost-saving option. So you get outputs such as the total cost, quality-adjusted life years, whether the pathway is cost-saving, the percentage of the viremic population that's diagnosed, and the cost per diagnosis. And so in this situation, the cumulative outcomes for this pathway are much better because there's a significant reduction in cirrhosis, HCC, and liver-related deaths. So this is one of the outcomes that can be compared between different pathways. And in some situations, the cost per diagnosis might be higher for the cost-saving pathway due to the averted disease management cost, still making that pathway cost-saving. So there are also total cost outputs where you can see here the selected pathway is the cost-saving pathway due to the averted disease management costs. And so in summary, we've developed this online open source tool to assist with making decisions in varied settings. The tool really allows users to customize this to their location. So the cohort size can be set to, for example, a specific program's area, and all the parameters can be changed so that appropriate and cost-effective or cost-saving strategies can be chosen in different locations. And this can help the programs make informed decisions that improve outcomes and are either cost-effective or cost-saving. And like I said, it is still in development. We're adding more countries to the tool. So Sonyal at Find, one of our collaborators, is in charge of helping add countries to the tool, and we have an input sheet. So if you're interested in adding a country, you can reach out to her.
Excellent. Thank you, Maddie.
Thank you.
Thank you very much. Very important tool to get people into developing programs to provide testing for their populations. One other aspect that we have some time to delve into is the importance of partnerships, public-private partnerships. It's very hard for any one individual or organization to put together an effective testing program. It needs multiple partners, and industry certainly needs to be there as a provider of high quality tests that are readily available at the point of care. So we have an opportunity to have Dr. Reddy from Roche Diagnostics in India to give some remarks about, from that industry perspective, as we face the challenge of testing really billions of people to reach these elimination goals with the prospect of averting 25 million deaths from hepatitis in future years. Mr. Reddy, are you on?
Thank you, Dr. John. And before I start sharing my screen, just give me a second. Share.
There we go.
Wonderful, Dr. John. Thank you very much. And in fact, I was just following through the session, and it is such a nice flow. We could see Thailand experience. We could see what's this access all about and what Find is doing. And we heard from Dr. Kumud. So such a nice flow. Hats off to you, how you have made it. With that, I just wanted to start my small talk. Actually, as you rightly mentioned, we are into diagnostics. We are a reputed organization, and that actually keeps us more committed, and that keeps us more go every day extra mile. Thank you for having me as a speaker at this very first Asia Pacific Hepatitis Virtual Summit on the occasion of World Hepatitis Day. The ultimate course of pandemic is still unknown. We have come across many challenges and have learned new lessons. The key learning is that we have to start focusing on finding a permanent solution, make our healthcare infrastructure so robust that no patient has to worry about his safety anymore. As we combat COVID-19, we cannot take our eyes away from infectious diseases such as hepatitis that have been growing at a significant pace in India. And I assume similar is the situation in the Asia Pacific countries. We have to make sure that we use this opportunity not just as a challenge, but to create more diagnostic infrastructure and make it so that it is future ready. For this to opinionate, actually we have our Honorable Prime Minister Modi in his inaugural address yesterday for COVID-19 labs in Calcutta, Mumbai and Noida. He mentioned that these labs will not remain restricted to testing COVID-19, but will be expanded for testing of many other diseases, including hepatitis B, C, HIV, MTB, dengue, etc. for future. So that's really a welcome note. I really felt so happy listening to Mr. Modi. Coming to Roche Diagnostics, as the topic says, options for hepatitis testing and experience of collaboration with government to address affordability issues. Access and affordability, I take it as in key words here. So thanks to the national program which is rolled out in 2018, I know that in the previous sessions it is probably been elaborated fully about the national program and how the other states have taken up, etc. I wanted to limit it to the experience what we can share, if that can be of help for other people. So we are committed as Roche, doing now what patients need next. This is our very purpose statement, and we wanted to be an active partner to end hepatitis. In this journey, prevention, diagnostics, treatment, and monitoring are the key. We all should help program not to get deprioritized and help achieve. We stick to the vision. You all know that present COVID actually has really taken away a lot of healthcare efforts and lot of healthcare funding, etc. But I request all of us in this program to be committed to ensure that the vision on the hepatitis is not lost in this pandemic scenario. As the leaders in infectious disease, Roche globally dedicated to support goals on eradicating the disease. Our Global Access Program is one big example in this direction. So it highlights our commitment to improve access to cost-effective resources, implement scale-up programs, and contribute to the elimination of disease to save lives and ease suffering of the patients. The program provides health system with transparent and consistent pricing to these important diagnostic tests such as hepatitis B, hepatitis C, and we are not limited to only these two, also HIV, HPV, and tuberculosis, etc. So you can see on the slide the disease burden in case of hepatitis is enormous, combining hepatitis B and hepatitis C, and especially in the Indian context I am talking about. So the objective of GAP is to provide access and affordability. And we are also in this journey, it is not possible that we can do it alone, and we are completely aware of that. Partnerships are going to play a very important role to end hepatitis by 2030. In that direction, we are making associations, and we are collaborating with private partners. We are collaborating with ministries of health, non-profit organizations, and even the labs and clinicians also. Slide. So as Dr. John has mentioned, one of the very important aspects on any infectious diseases, especially in hepatitis, the public-private partnership is going to play a very important role. Roche has some success in the other programs, probably that can help hepatitis program also to adopt and really get more success. So I just wanted to touch upon one program which is prevention. That is the reason I have put this particular NAT program here. So one of the very clear objectives of any infectious disease is better to prevent, right? So in that language, in hepatitis also, if you really see, there are blood donations. The hepatitis can be transmitted through blood donation. So for example, in India, one state, Odisha, made a headway. Before 5 years, they have started NAT testing. We really collaborated with them in making a multi-centric project. This is one of the finest examples of public-private partnership, where the strengths of private partner in establishing the instruments and inventory management and the sample transportation, etc., and the government taking the prevention as their one of the important goal. So that is one aspect I wanted to cover. And the second is end-to-end solutions. See, we learned in the HIV program in the country, right? Governments, for them, patients coming to the hospital probably is not a biggest challenge. Of course, this is a challenge, but not the biggest challenge. But once the patient comes to the hospital, how many layers are there? How many things need to be done, right? So sample collection is a challenge, and sample transportation is a challenge. And in hepatitis especially, you know that monitoring is a challenge. We don't want them to just go away after getting tested positive. So viral load testing plays an important role. So in this example, where we have the national program in HIV, we have partnered with private partners, especially Metropolis, and we have made end-to-end solution possible. For example, the particular program encompasses the from the sample collection, transportation, the pre-analytics, analytics, as well as the result reporting. So that way, I can proudly say that the program so far so good, running successfully. So this can be one best practice sharing. And offering disease management solutions using centralization. This is going to be an important piece, right? So obviously one size doesn't fit all. I am not just trying to say that centralization fits everything, but at least in centralization, you have like downstream applications also can be done. For example, if a sample comes in and we detect it as positive, and then we wanted to do things like genotyping or sequencing, etc., that will be of big use, right? Meaning centralization can really help. And the patient management also, end-to-end, it becomes relatively easier. So this is just on the slide as an example of what private partner can do. We have established tens of the machines, so which can really ramp up the testing from 1,000 to 1,500 samples a day, right, to a 5,000 sample day capacity also. So initial challenges we have seen, pre-analytics, interpretation of the results, etc. But now when we have plugged the end-to-end solution, as I have covered previously, that really helped run the program in a better way. We are proud to be partnering with the government on the national HIV program, right? So as I move towards the end of my session, I would like to take your attention that none of the players, neither government nor private, can offer a complete solution, right? So a partnership is going to be very instrumental in the success, and centralized testing benefits also to be considered. I want to take your attention to the fact that name any infectious disease, whether it is COVID, hepatitis, the goal is eventually to get rid of them. Diagnostic testing plays an important weapon against these diseases. And lastly, on the World Hepatitis Day, we at Roche stand with the hepatitis community in our commitment to not only find patients with hepatitis, but do every bit in order to provide access to safe, affordable, and effective prevention, testing, and monitoring services. With that, thank you very much, Dr. John, and thanks everybody for this opportunity.
Thank you very much, Mr. Reddy. Really a nice overview. It's really great to hear that commitment from Roche on World Hepatitis Day, and we really appreciate Roche being a partner in the Coalition for Global Hepatitis Elimination. So thank you. I'm going to thank all the speakers for an excellent set of presentations that really touched on a number of important issues, and we heard about some useful tools that will be made available to us to even improve our precision in our planning in the future. We wanted to turn in our remaining moments to launching another tool, which is an access to care tool that has been put together by Dr. Surin and his colleagues. Is Dr. S.K. Surin on the line? Yes. Prasad,
John,
yes, go ahead.
Yes, Dr. Sarin is on the line. So request Dr. Sarin to switch on the video. Yes. So here we go, John.
Okay.
Good afternoon for the Indian colleagues, and very nice to see John and everyone else. And thank you for calling me for this event. Apologies I couldn't join earlier. It's a good initiative. I have no conflict of interest with what Prashant Mohanty does, because he has been in his own way a leader by trying to innovate how to get the hepatitis drugs or hepatitis diagnostics to the people. He has worked for umpteen number of years, and I would like to say that even when we were planning our first Asia Pacific conference in 2004, which was a major success of about 3,000 people in those days. Now you don't see all this. Prashant did a lot of work. He has always been happy in going to an unconventional way, but it was not always successful. Today I find that this program, and I heard part of the sessions which were running, I think that there was a huge vacuum of how to connect people, those who have the disease or the infection, and the clinicians. Therefore, this access program hopefully will be good. But the success will only depend upon transparency, the honest way in which the patients, without having to pay extra, can reach the doctors, and doctors have no vested interest. So it doesn't work like there is a middleman, or I must not use that word, but there is no middleman. But yes, there is a genuine expenditure and there is a genuine reward. With that in mind, this becomes a key chain connector. The patient access programs in other parts of the world, I'm not very well aware. But at ILBS, we have an empathy program, and we had a e-conclave. Empathy means empowering people against hepatitis. And this program was launched 2 years ago with the Airports Authority of India, and had nearly 15 million viewers on that. It goes to the schools and others, and also to the patients. And it has a small program of networking the patients. What I find difficult is that one person doesn't speak to the other. The patients want to discuss, knowing that the other patient is also hepatitis B, they don't talk to each other. So there is a huge challenge and a stigma for which we all need to move, that they are not discriminated, marginalized, or stigmatized due to just being happy positive. So how to break that is a challenge as a clinician, as a person involved with them. The second part is, which I would like, and my suggestion to the whole team, which I find Ruchika, if I can pronounce the name correctly. There are many other good people involved into this. My suggestion to all of them would be that if you want to make this as a successful program, please see that it is not commercialized. You are going to many other diseases where the interest could be of short duration, but here is liver diseases which have long-lasting programs and long-lasting connection of patients and doctors. So with that in mind, I would congratulate the team, and I would be very happy that this program succeeds so that we are able to reach out to people. The doctors have just to say, well, this is the treatment, you're the right person. And yesterday I also gave this in one of the WHO seminars, and I want to communicate, and I hope John and others take this to another level. In HIV, we treat all. In Hep C, we treat all. In Hep B, we question whom to treat and whom not to treat. And I think from 2007, we have been championing. We tried to change the name, that drop the word carrier. Everyone is chronic HBV infection. So 22 years, 1999, we were the first in the Indian Society of Gastroenterology to say drop this word, and I'm happy EASL, APHS, ASLD all have said chronic HBV. So could we not all move ahead and say for Hep B at least treat all? And this is one of the things which will eliminate those who are infected in a way, prevent transmission. One more time, thank you for inviting me, and I hope as a team we all can make the patient suffering and patients' outcomes better. Thank you all.
Thank you very much, Shiv. So nice to hear your perspectives on the guiding principles around the use of this tool, and some really inspirational comments about looking ahead for hepatitis B and hepatitis C elimination. Prasad, did you want to show a video of demonstrating the tool? Do we have time for that?
Yes. So thank you, Professor Sarin, for your kind words. And with this, we request you to formally launch our Access to Care program. Today, on the occasion of World Hepatitis Day, we are starting with an innovative project, Virtual Liver Care, and subsequently we'll move to other diseases. So, Deepak, please play the video.
Chronic diseases are everybody's business. Many of us suffer at least one chronic disease during our lifetime. Some of the most common chronic diseases relate to liver, respiratory system, diabetes, hypertension, heart diseases, cancer, infectious diseases, and mental health. Unfortunately, most chronic patients do not get timely diagnosis and right kind of treatment they need or desire. This is mostly due to unequal distribution and shortage of healthcare resources. For example, the doctor-to-population ratio in India is 1:1,404 against WHO norm of 1:1,000. Other factors that make a patient's treatment journey difficult are inadequate diagnostic and treatment facilities, non-availability of specialist doctors near to home, lack of guidance and psychosocial support, which eventually lead to late access to care and high out-of-pocket expenses on healthcare. This is where IIHD can step in, enabling patients access to continuum of healthcare and simplify the care pathway with its unique virtual access to care program. A2C virtual platform offers personalized patient and doctor support services that attempt to serve e-consultations, diagnostic and treatment services, rehabilitation and palliative care, psychosocial counseling, financial support, and other needs in the healthcare value chain. Features like electronic health record, appointment management, online sharing of diagnostic investigation, e-prescription, and information on latest medical advancement helps doctors to efficiently serve patients in a hassle-free manner. Convenient access to comprehensive healthcare facilities at one place helps save time and money. By simplifying the patient's care pathway, IIHD stands committed to serve for social impact and help them lead a fuller and better quality of life without any compromises.
Excellent. Look forward to learning more about that tool and how it can be applied to hepatitis care and treatment. I think we are up against the end of our time, I believe. I think if time permits, we do have a video message from Dr. Sue Wong, who is the president of the World Hepatitis Alliance. Prasant, do we have that video ready?
Yes. So, Deepak, please play the video from the president of World Hepatitis Alliance.
World Hepatitis Day 2020 is an important landmark for the hepatitis community. We are now just 10 years away from the 2030 elimination set out by WHO in 2016. With concerted effort over the next decade, we can eliminate this global killer and save millions of lives. Sadly, 2020 is also the year the COVID-19 pandemic gripped the world. This crisis has had a significant impact on the viral hepatitis community, with prevention, testing, and treatment services affected, and many people living with viral hepatitis facing difficulties in obtaining the care and medications they need. I'm acutely aware of how the pandemic has affected World Hepatitis Alliance members and your plans for World Hepatitis Day. But I also know the resilience of our membership in the face of adversity, and I have full faith that the hepatitis community will utilize every opportunity to raise awareness on July 28th. World Hepatitis Day is our day to speak in a united voice and to celebrate how far we have come towards eliminating viral hepatitis. It also gives us time to pause and reflect on the countless lives that have been lost to these diseases, despite there being a vaccine, an effective treatment for hepatitis B, and a cure for hepatitis B. This year, on World Hepatitis Day, the World Hepatitis Alliance and the No Hep movement are calling on policymakers to keep the promise they made to eliminate viral hepatitis by 2030. Viral hepatitis is a global health crisis, but one that can be overcome. Progress is being made. Over 124 countries have developed or are developing elimination strategies. However, many of these strategies do not have funding. WHA has just released a new report from India Punjab state, which lays out the financial case for hepatitis B elimination. It shows that scaling up their response to ensure they reach elimination by 2030 is not only achievable, these financial cases are imperative as the world implements a financial outlook. It will be far too easy for governments to do nothing. However, hepatitis elimination now will save money, strengthen health systems, and avert over 7 million deaths. One of the easiest and most cost-effective interventions is the prevention of mother-to-child transmission, PMTCT. On World Hepatitis Day this year, the WHO will be releasing new guidelines on hepatitis B PMTCT. This is an issue which is particularly close to my heart. As someone living with hepatitis B and a mother, one of the most important milestones in my life was seeing that the PMTCT intervention worked. My children have all tested immune and they are hepatitis B free. I don't have to live with the burden of having passed on this lifelong infection to my children. It is unconscionable that with the tools we have available, there are still many children infected every year with hepatitis B. We must ensure that birth dose is given to all children. But that alone is not enough. All pregnant women must be screened for hepatitis B so that we can identify those who may need antiviral treatment to prevent transmission to their infants, but also for their own health. Countries must integrate hepatitis into maternal and child health services in order to protect their next generation. This also must be seen as a women's health and women's rights issue, because viral hepatitis elimination will not be achieved without gender equality. It is my sincerest wish that World Hepatitis Day 2020 is a catalyst for action, even in the face of the COVID-19 pandemic. Let us raise our collective voices and work together to eliminate hepatitis. Thank you for your commitment, and I wish you a highly successful World Hepatitis Day. Thank you.
Thank you. Very fitting to have that closing remarks from Sue Wong, the president of the World Hepatitis Alliance, and a close colleague. just in my closing remarks, I want to thank all the speakers in both sessions for really touching on all the important aspects of testing and really remarkable programs that are underway in India, Thailand, in other parts of the world. And even though we are only have a few countries that have reached these interim targets for mortality reductions, there's a lot of momentum moving us forward in a very, very positive direction. And that's one of the objectives of the community of practice that we're forming at the coalition, so that these kind of discussions can be going on an ongoing basis, so people can learn from each other, help their programs improve or help their programs get going in a way that wasn't possible before. So I look forward to bringing all these slides and the comments that we have had over the last 2 hours into our evidence base in our community of practice, and really encourage all the partners that are evident on the call today to continue to be connected through the Coalition for Global Hepatitis Elimination, so that we can really continue to have that global network that will help us all be successful and then reach these global hepatitis elimination targets together. I want to thank IIHD for bringing this webinar together, and look forward to continuing to work with all of you to reach our goals for hepatitis elimination. By working together, we will eliminate hepatitis. Thank you. Prasan?
Okay. So thank you, John, and thanks everyone for your time. Just before we conclude, I just want to say that the Access to Care program, which we are launching, or the virtual liver care, it's actually going to use the technology. And we have a technology partner. We would like to thank Medipal, where we are going to offer the teleconsultation facilities. Then we are going to partner with Project ECO team in terms of capability building. We are looking for a partnership with Roche Diagnostics, where we can provide access to diagnostic to those patients, as well as with all the academicians and the clinicians for their support to make a grand success for virtual liver care. So with this, thank you very much once again. And thank you especially, John. Too early in the morning for you, but you took your time and spending more than 2.5 hours for us. Okay, so we have a break now. Then at 3 o'clock, we start the session 3. The session 3, we are going to talk about the role of civil society and the Doctors Association in achieving the elimination of hepatitis. So have a good break now. Unfortunately, this is a virtual conference, so we cannot provide the tea lunch. Sorry for that, but we look forward in the future. Thank you once again.
Thank you very much. Bye-bye.
Bye-bye.